Thank you all. I'm going to give you some remarks. Did I just kill that? No, here we go. So I'm going to give you some remarks from a CDC perspective. They're not meant to be that I suggest that they're just our jurisdiction, because obviously there's a lot of other players in this world. But the first thing I'd like to talk about is the planning that's happened so far. So I think you all know HHS gave CDC money to fund 32 jurisdictions that support the 57 EHE phase 1 jurisdictions to conduct a rapid planning process. Those who aren't aware, most people in the room probably are aware, but CDC has direct funding relationships with the state of California, with Los Angeles County, and with San Francisco. So there are 3 separate awards that went for planning for those. And we're looking at the map here. You can see that there are some jurisdictions where a regional approach to implementation may also make sense. I've not read all the plans, so I can't speak to all of them. But for instance, in Georgia, where we're located, the 4 EHE counties are really metropolitan Atlanta. Those 4 counties plus 1 more are really metropolitan Atlanta. So they're already working very closely together on their plan. And then you look in Florida, the 3 southern counties are the 3 relatively big counties that are next to each other. And there's 3 central counties as well in Florida. And then in Maryland and DC, the 2 counties in Maryland border the District of Columbia. And so I'm not sure how much the plans will come in that way, but there are some opportunities for regional approaches to EHE. So I'm going to present some concepts under each of the pillars that might be addressed regionally. And again, these might be some things you're already thinking of, you're already doing, so I don't be pretending to be the only one with ideas. And again, it's a CDC-centric thought of it, but not to imply that it's our jurisdiction alone. So the first around Diagnose, I think you know that about 86% of persons with HIV infection had received a diagnosis and to accomplish the goals of EHE, we need to increase HIV testing to increase knowledge of status. So of course, this can be addressed through routine testing in healthcare settings, rescreening persons at high risk for HIV, and then innovative strategies in non-healthcare settings. I think one example of an innovative strategy in a non-healthcare setting that can be applied regionally is to establish HIV self-testing programs regionally. CDC just published the eStamp study in JAMA in 2019 that demonstrated that the distribution of self-test kits to MSM through social media, through internet-based mailing of self-tests to people, was successful at engaging persons at risk for HIV infection into HIV self-testing, thus increasing awareness of HIV infection. There are some examples of distribution of HIV self-test kits. In Philadelphia, they have via an internet site. There's one in Philadelphia and one that's just recently started in Baltimore as well. But other models could be through the internet or through distribution of coupons from CBOs or clinics for HIV self-test kits where they can be redeemed at pharmacies. So you give them a coupon. You don't have to necessarily stock kits everywhere. Just give them a coupon, they can go redeem it. And it can also use a social network strategy to give multiple coupons to an individual to give out to their friends or persons they think might be at risk for HIV. In terms of treat, one of the concepts is one concept might be to establish a health department hotline to triage new diagnoses and to be able to report to public health and to help with linking people to care and re-engaging people in care. So a regional approach might be whereby one hotline serves multiple jurisdictions by staffing one call center that manages the information that comes in. Another, of course, is data to care, and California is already doing this. A lot of the data to care can be coordinated at the state level, and then the line lists are shared with the counties. But then a regional approach would be through data sharing agreements across counties to be able to share information and to look for out-of-care patients across counties. Another would be data to care using medical claims or pharmacy claims data to identify people who've stopped filling prescriptions for antiretroviral therapy at a claims level. And so this could be done with like Medi-Cal data or with private insurer data or through a claims adjudicator, with the interventions then operationalized through the pharmacy or through the clinic or through the health department. So obviously the claims data will likely cover more than one jurisdiction. So one insurer might be across all of Southern California. For prevent, for a regional idea for PrEP, obviously teleprep is a promising technique to engage people in PrEP who may not want to visit a traditional brick and mortar clinic or live a distance from the nearest PrEP clinic. I understand that California started to use a vendor for teleprep, though there may be other vendors as well. So a reasonable approach would be to be marketing one or few vendors that the different counties can kind of buy into to get people to use to access teleprep through the same process. For syringe service programs, you already have a statewide approach for registering and approving syringe service programs, and that's actually very so it's already regionalized, and it's already a huge step forward compared to sites that don't have that. And one of the great benefits of that is the ability to use to also receive materials from the California Syringe Exchange Supply Clearinghouse. So we already have this in place. I understand not all counties have SSPs or have approved SSPs. What this does is once they get over, if they address that, this approach enables the counties that have not yet started the SSPs to have a process to rely on to start, so they don't have to figure it out themselves from scratch. And another is that non-prescription syringe sales, California law and regulations allow pharmacies to sell syringes without a prescription. They actually provide, so this activity can be regionalized since the program provides the pharmacist with guidance on what needs to be done regarding distribution and disposal of syringes. So it gives the pharmacist kind of direction if somebody walks in for syringes, they're not just getting hit cold. They actually have a process that they can follow. So in this, obviously, you could also add other things to this with the coupons, with self-testing, vaccination, naloxone distribution. And a regional approach would be to work with the pharmacies in the area to embrace them as part of the EHE, to have them all get that to be part of the program, so they're not all out there trying to figure out what it is they're doing on an individual, pharmacy to pharmacy basis. And then last, with respond, obviously with cluster detection, time-space cluster of an increase in diagnoses among a particular group of people over a relatively short period of time may be noticed in one region. But a molecular cluster identified via secure HIV trace may be noted at the state level and may involve people from multiple jurisdictions. So obviously, in those situations, jurisdictions can share data and have established communication channels. For instance, having regularly scheduled calls across jurisdictions to discuss ongoing cluster investigations. And then the response can also be regionalized, since it's possible that people in the cluster, of course, are in different counties, or they may move from one county to another. So this might require establishing data sharing agreements and then creating MOUs for how to use staff for surge capacity across the jurisdictions. For instance, if you need to share DIS or share testing staff across jurisdictions. Now, obviously, a transmission cluster is evidence that the prevention services have not adequately reached the network. So when communities are planning for how to use data to find and address these gaps, it's obviously very important to involve members of the local communities themselves in the planning and in the implementation and the evaluation of the cluster response. The phrase I use there is make the community part of the solution, don't make them feel like they're just part of the problem. And obviously there's a lot of other things that can be done leveraging community resources and expertise around cluster response that need to be thought about. So with that, I will stop and turn it over to the next speaker.